Hi, my name is Petr and I work for the Helmholtz Research Institute in Dresden in Germany. And I would like to give you a practical introduction to arterial spin labeling, abbreviated as ASL, which is an MRI technique for measuring perfusion. And the aim of my presentation is twofold. First, I would like to give you a light introduction to ASL, explain the basics, the theory and applications. And my second aim is to provide you a practical guide for starting using ExploreASL yourself. So I will provide you the most important tips and hints and references to the articles that will help you starting using ASL in clinical research or clinical practice. I will first explain you the basics of ASL, then show you some examples of how to use ASL in clinical research and practice, and I'll finally give some practical tips on how to get the sequence, how to set up the protocol, and how to evaluate the data. ASL is a non-invasive MRI technique to measure perfusion from the 90s, and it's mostly used in the brain. There is no injection of any contrast agent or radio tracer, and the big advantage is that it provides absolute quantification of perfusion, so we can reliably assess perfusion also across time. In ASL, magnetically labeled blood is used as a tracer. The blood is labeled using a 180-degree inversion pulse in the brain feeding arteries in the neck or below the brain. Then we wait for around 2 seconds until the labeled blood reaches brain, and then we take a standard 2D or 3D image of the brain. This image somehow has a modified intensity based on the inflow of the labeled blood. We repeat this process 2 times with and without prior labeling, and these 2 images, they differ slightly, around 3%, and if we make a subtraction of these 2 images, it is perfusion weighted. And with proper quantification, we can derive the absolute values of CBF in milliliters per 100 gram per minute. Here is an example slice from the CBF map. To obtain images of such quality, we usually need acquisition time of 3 to 5 minutes, which is pretty good also for clinical applications. ASL resolution is usually around 3 by 3 by 5 millimeters, though we can choose also slightly better resolution. At 3 Tesla and at 7 Tesla, we can get resolution up to 2 by 2 by 2 milliliters. Even at 3 Tesla, it's easy to obtain whole brain coverage, and when we look at the repeatability across sessions, then we are at roughly 10%. If we look at the whole brain values, it will obviously be slightly worse when looking at the voxel-wise values. ASL has many research applications. The big advantage of ASL is that it provides absolute measurement of perfusion, so it offers a range of possibilities of study designs that can be used for ASL experiments. It is well suited for cross-sectional or longitudinal studies. We can compare our results with a control group or just study perfusion patterns on a global scale or on regional scale or also on voxel-wise level. Since ASL is completely non-invasive, it can be used easily in healthy volunteers, and it's super well suited for studies in normal brains. So there are plenty of applications where we can use ASL in normal appearing brain, in normal brain development, psychiatric disease, pharmacological studies, functional studies, or to study sleep disorders, for example. But there are also a range of pathologies where perfusion is relevant, for example, study of brain tumors, neurodegeneration, epilepsy, stroke or stenosis. These are just examples. Of course, there is no limit to use ASL and it's relevant for all applications where perfusion is a relevant parameter. While designing ASL research studies, you should be aware that there are many physiological confounders for perfusion. Now, please pay attention to the article I cite at the bottom of this page. So throughout the presentation, I will not try to cite papers with the newest ASL findings. Instead, I will always give references to interesting review articles that provide more information about each topic. So I warmly recommend, if you're interested in ASL in a specific topic that I give at each slide, try to look into these references for more information. Back to the physiological confounders, there are many things that can make perfusion higher. They're all listed in this nice review paper. So, for example, hypercapnia or exercise increases perfusion, but there are also many things that decrease perfusion. For example, age of the participant or intake of caffeine. There are also things that confounds the measurement itself. For example, the hematocrit level that will not alter the perfusion itself, but its ASL measurement. Now, in the next few slides, I would like to give you an overview of the possible clinical applications of ASL. So first, I have to say that ASL is not used on a routine basis. Most radiologists are not familiar with ASL, so the clinical use is really a domain of specialized centers and a few clinical experts that are really familiar with ASL. So you don't have to worry that you're not using it in your hospital. Most hospitals don't. There are, however, certain pathologies where ASL is an alternative sequence that can provide similar information as some other sequences used. And there are some cases where ASL can really have a true added value. So in the next slides, I will provide some examples of how ASL can be used to image neurodegeneration, brain tumors, arteriovenous malformations, stroke and stenosis, or how it can be used in pediatric imaging. And again, please, if you want more information about clinical use of ASL, check these two papers that provide really great information and that I've also used to create this presentation. A typical use case of ASL are neurodegenerative diseases. There are specific patterns of hypoperfusion that are seen in many types of dementia. We can see hypoperfusion in Alzheimer's disease, vascular dementia, or frontotemporal dementia. Nevertheless, this is not really used in clinical practice, but there's a lot of clinical research going on into studying the role of ASL as an early biomarker of Alzheimer's disease, and people are also checking if this can be used as a prognostic biomarker for AD, and hopefully in the future it will also help as a potential biomarker for screening for AD. Practically more useful application of ASL are brain tumors. ASL signal is sensitive to tumor vascularization, so it can be a useful complementary or alternative technique to DSC or post-gadolinium contrast T1 weighted images. You can see in this example that it gives pretty similar results in ASL as DSC or post-gadolinium T1 weighted image in this IDH wild-type glioblastoma. And there are also some cases, for example, this oligodendroglioma, where we can see increased perfusion on ASL, but not really so much increased perfusion on DSC, despite that PET imaging confirms that there is increased perfusion. So there are several use cases of ASL in brain tumors, for example, to differentiate progression from pseudoprogression, and there is a lot of clinical research going on now to study if ASL can be used to replace gadolinium in brain tumor imaging completely. Now, I would like to give you 3 more examples from the latest publication by Lindner et al. The first one are arteriovenous malformations. So in those, because of the very slow flow and large vessels, we can see very high hyper-intense signal on ASL. Further typical application of ASL is stroke and stenosis. So while no signal on ASL is a sign of no blood flow, when there is a decreased perfusion but with few focal spots of increased signal, this is a sign of a delayed flow, typically through collateral vessels. In this example of 30-year-old female with headache and left side weakness, the initial findings on CT and CT angiograms were negative, but if we looked at the ASL, we could see decreased perfusion and few bright spots, which indicates a clear increased arrival time from neck to the brain, and therefore indicates diffuse stenosis or collateral flows, which led to further retrospective review of the CT, which confirmed a reversible cerebral vasoconstriction syndrome. My last example is application of ASL in pediatric patients. ASL is well suited for pediatric imaging as it's safe and non-invasive, especially compared to perfusion imaging using gadolinium. In this example, there was an 80-year-old boy with acute onset left hemiplegia. The classical stroke MRI with MRA, diffusion-weighted imaging and FLAIR all proved to be negative, but on ASL we saw a reduction of CBF in the entire hemisphere, and the patient with the complex hemiplegic migraine recovered without intervention. So now that I'm done with the examples of use of ASL in clinical research and clinical practice, you might be asking yourself, well, I would like to use this sequence, but there are many practical questions that stand in the way. For example, how to get ASL, how to set it up, how to evaluate it, and what are the major drawbacks. And in the next few slides, I would like to give you basic answers to all these questions to motivate you to start using ASL. The first question you'll have to face is what sequence to use, because there's so many available. There's pulsed ASL, pseudo-continuous ASL, velocity selective ASL, and acceleration selective ASL, just to start with. But the answer is pretty simple. You can just use the pseudo-continuous ASL or PCASL, because it's just good enough for 90% of the applications, and it is widely available as a product sequence on scanners by all vendors. So there's only one catch. You need to buy the sequence. If you don't have the sequence, you can't just use any research sequence. All research sequences have as a requirement deal with the vendor that you will buy the product. Once you buy the product, it's pretty easy to approach scanner developers, sequence developers from academia, and ask them for any advanced sequence. It's fairly easy to set and plan an ASL sequence because you mostly need to plan a simple axial scan, or you can align it with the ACPC line. The labeling plane usually doesn't have to be planned because it's simply parallel to the imaging volume, and you just have to be mindful that the labeling plane is reasonably perpendicular to the brain-feeding arteries. There are, of course, some specific ASL settings, but all of these can be read in the great ASL white paper from 2015, and there are some recent updated recommendations how to slightly alter these parameters for different diseases. So if you read these two articles, you learn all the necessary things about how you should configure the sequence and how you should plan it and what should you be careful about when it comes to the acquisition. If you're interested only in clinical evaluation, then you don't need any complicated post-processing tools, because all the product sequences on all scanners, they now provide the perfusion map directly on the scanner. So you can just look at the images produced directly at the scanner, visual assessment and basic statistics on the clinical console is perfectly fine for clinical reading, and you might just want to adapt the settings and evaluation based on pathology. For that, I again recommend reading these two articles which provide more details about this. The evaluation of ASL data in research becomes more tricky, and you'll probably want to use some special software for that, unless you want to write your own software, which is unnecessarily time-consuming. So the main issue comes if you plan to create and share large data sets from several sites, because there might be differences in how ASL is implemented in different scanners, there'll be missing data and so on. So if you know that you'll be working with data from more sites, or if you plan to share data with more people, then I would recommend to use the ASL bit structure to save and share the data. So this ASL bits format provides a non-ambiguous way how to share, store and share data from several subjects acquired at different sessions, also containing structural images, and it's all saved in the Nifty format, but there are also JSON sidecars that contains all the metadata. And this format is able to handle most ASL sequences. However, there are still issues with conversion from DICOM, as not as all ASL texts are saved in DICOMs. And while there are some pipelines that already support processing data saved in bits, the support is still not universal. So while I would nevertheless recommend saving data in the ASL bits format, you still have to wait a bit until all conversion tools and all processing softwares support it. Processing ASL data in research is not really more complicated than processing any other MRI sequence. There is a number of steps that should in theory be done, like working with the FLIR images, segmentation of the structural images, registering to the MNI space. Then the ASL data itself should be motion corrected, aligned with the structural data, quantified, and then evaluated in anatomical regions. So these are quite standard steps, and you can check these two articles that detail all of them and provide like a technical overview or an overview for clinically oriented people. And while it might seem that there has to be a lot done to process ASL data, there are several quite good pipelines available that will do all the steps automatically for you. The question, of course, is what pipeline should I use to process the data? So I can, of course, recommend our own pipeline called Explorer SL. It is freely available on GitHub, and it's completely free for non-commercial use. The basic interface is command line in MATLAB, but we are also now offering a free graphical user interface, as you can see here. If you're not happy with just this one choice, then you can consult the ASL inventory available through the OSIPI, Open Science Initiative for Perfusion Imaging. And here we offer a list of all available ASL pipelines. We provide an overview of features of all these pipelines, and we have also tested a selected group of publicly available pipelines to assess how easy they are to use for beginners or for hardcore programmers. So if you go to this webpage, to OSIPI Task Force 1.1 ASL Software Inventory, you'll hopefully have a clear view on what pipelines is suitable for your task and easy for you to use. And very soon this overview will also be published in Magnetic Resonance in Medicine. Unfortunately, ASL comes with plenty limitations as well. The major limitation is probably the general quality. ASL resolution is about 3 by 3 by 5 millimeters, so this leads to mixing signal from different tissue types like white matter and gray matter, and partial volume correction is advised. SNR is limited, especially in the white matter, which has a very long time for blood arrival. So during the analysis, we have to focus mostly on the gray matter, as the signal from white matter is not really reliable. And the acquisition is quite susceptible to motion. You can see motion can generate plenty of artifacts and destroy the signal. And while motion correction solves this situation in most cases, it's by no means a universal solution. You can check the article here that provides some more information about typical issues with processing and how to address them. The second major limitation of ASL are arrival time artifacts. So we usually wait around 2 seconds between the labeling and imaging, which is sufficient only in the healthy and young people. In older patients with disease, this is very often insufficient, which leads to decreased signal and artifacts. As we can see on this example of a patient with stenosis on M1 segment with collateral flow, the perfusion seems to be decreased here and here, but if we increase the delay between the imaging and labeling to 2.5 seconds, then suddenly we see that the tissue is nicely perfused and we can measure that. The problem is that, of course, we cannot increase the delay indefinitely, as this would decrease the SNR of the imaging. So it's good to follow some recommendations about what should be the what should be the delays for specific diseases and populations, as indicated in this article. Last but not least is the issue with labeling plane. So optimally, the labeling plane should be perpendicular to the brain feeding arteries to reach the maximum efficiency of the labeling. However, this is not always possible, and we can see in this example that the labeling plane is not perfectly perpendicular to the left ICA, because the ICA is tilted, and this results in suboptimal labeling, and we can see decreased perfusion here. If we move the labeling plane in the same patient 2 centimeters below, we nicely hit both left and right ICAs, and we obtain a really nice perfusion image in both vascular territories of both ICAs. However, we don't hit the vertebral artery anymore perpendicularly, as it bends in the location of the labeling plane, which results in decreased measured perfusion in the posterior part of the brain. And of course, in the worst case, if the vessels are completely tortuous, then we cannot really expect any nice images. You can then again check these articles for certain recommended strategies on how to position the label in plane in difficult cases. ASL of course doesn't stop at the simple techniques I've just described. There's much more you can achieve with advanced ASL. So for example, you can acquire images at several different delays after the labeling, and with that you can obtain maps of the arterial arrival time. You don't have to use ASL only in the brain, but there are plenty of body applications available, mostly in the heart, kidneys or liver. And there are many new advanced processing techniques to process the ASL data and derive new information from that. So if you're interested in these advanced techniques, then I invite you to read these 3 recent excellent reviews. And ASL is of course going through continuous development, so there are many new sequences that we can look forward to. As 2 examples, I would like to mention first the BBB ASL that measures the permeability of the blood-brain barrier. So we don't only have to acquire the CBF maps of the perfusion, but we also acquire the exchange time of the blood across the capillary walls. And as another very promising technique, I would like to mention the combined perfusion measurement and angiography. So with a single measurement, you can obtain the perfusion maps, but also high-resolution, time-resolved angiography of the brain. With that, I would like to conclude my talk and give you 4 key take-home messages. First, ASL is a non-invasive tool that requires no injection of radiotracers nor contrast agents. It's repeatable, economical, and safe. Second, ASL is suitable for most pathologies, and in certain cases it has an added value in the clinics. Third, ASL is a useful and versatile research tool. Now, with new sequences and new software freely available, the research is becoming easier and easier to do. And 4, while ASL is still tricky, there is a lot of material to guide new users, and also the ASL community is very open and helpful. So please don't hesitate to start your new ASL research project, and don't hesitate to contact the experts for help. Thank you.